Well, welcome everybody. Thank you for joining our first ever Xerostomia support group. It's so nice to have such a big turnout. My name is Elizabeth Daly. I'm the Executive Director for the National Foundation of Swallowing Disorders. I want to thank you for joining us today. And for those of you who might not be familiar with the foundation, our mission is to advance the treatment of swallowing disorders in our lifetime. And we do this by offering support, providing high quality free education, promoting promising research, and raising awareness of the impact of swallowing disorders at the local, national, and global levels. And while not everyone with dysphagia or difficulty swallowing has xerostomia, many people with xerostomia experience difficulty with swallowing, which is why we wanted to offer this support group. I have a few housekeeping items to go over before we start our meeting. The first one, please mute yourself if you're not speaking, just to reduce the background noise. I can mute you on my end, but I can't unmute you. And as mentioned in the reminder email, this meeting is not a replacement for any type of medical advice or treatment recommendations. And we kindly ask that you respect each other on this call. We all come with different experiences and perspectives, and we're all here to learn from one another. So we ask that any personal stories that are shared stay here. The foundation does not endorse or promote any specific brands or products or treatment recommendations. As an organization, our mission is to provide resources and information and support to individuals impacted by swallowing disorders as well as people with xerostomia. This meeting is sponsored by Aquarel Oral Spray, and I have invited one of their company representatives to share some information about their product with us towards the end of this meeting, and we'll also provide you with some additional information in a follow-up email that we send out after this meeting. So here's our agenda for today. We will be using breakout rooms, which is relatively new for us. So please be patient as I try to figure that out. But please let me know also if you're experiencing any difficulties with that. You can either message in the chat or email me at info@nfosd if you're having any trouble. To be mindful of our volunteers' time, our two moderators, and as well as your time. We will wrap up the meeting at the top of the hour, but if you have any sort of follow-up questions or comments that you would like to share with us, please feel free to reach out at email. And with that, I would like to introduce our two volunteer moderators for this meeting. Dr. Kate Ciarrocca is the Director of Oral Medicine at Duke University Hospital, where she's a clinical associate professor in both the Division of Plastic, Maxillofacial, and Oral Surgery, and the Department of Head and Neck Surgery and Communication Sciences. She practices full-time at Duke University Hospital, both in the outpatient clinic, the operating room, and Duke Blood Cancer Center. Her practice focuses on medically complex patients and how that complexity affects the oral cavity. Kristin Winter is a speech-language pathologist who has specialized in treating adults with speech and swallowing deficits for over 25 years, providing high-quality evidence-based speech therapy for adults with a variety of conditions, including swallowing impairments, head and neck cancer, Parkinson's, and other neurological impairments. And with that, I want to thank them both for their time today. I'm going to turn this over to Dr. Ciarrocca here. Let me end my sharing and let you share here.
Okay.
All right, I'll stop presenting. And Kate, if you're able to share your screen, feel free.
Yes, I'm gonna try here.
Excellent.
Share.
And I'll let you know when you see it.
And
Right. Looks good. We can see it. Yeah.
All right.
Thank you.
So welcome, everyone. This is really exciting, and I'm honored to be a part of this group. And I'm going to talk to you today about a whole lot about spit and what to do when you don't have much of it. Just to give you an understanding of what it is I do and the specialty that I practice in, it's called oral medicine. It is basically a medical specialty of dentistry. So I'm a dentist by training, but I do not do dentistry. I do not, I'm not filling and things like that. I am managing medically related disorders or conditions that affect the oral and maxillofacial region. So I see a lot of xerostomia for a variety of reasons. So what we do at Duke, and this is really the same at pretty much any oral medicine practice, I will say I work in the same clinic with the speech language pathologists as well as the head and neck surgeons. So I'm kind of located in ENT, so head and neck cancer patients and radiation patients. But this list is just a variety of the things that oral medicine specialists manage. Lesions, mucosal diseases, a lot of oral ramifications of cancer and its treatment, autoimmune disease, xerostomia, and then other various clearances prior to surgeries. And as you can see, these xerostomia or dry mouth, Sjogren's, salivary gland disease, those are all very much a part of our practice. And so when we think about the orofacial complex, everybody sees, oh, she's a dentist by training, and they think teeth. And really, the orofacial complex is comprised of 5 different things: the teeth, the gums and bone that hold the teeth, the lining of the mouth or the soft tissue mucosa, the whole chewing apparatus, the TMJ and the chewing system, masticatory system. And then there are the salivary glands and saliva. And interestingly enough, the saliva aspect of this orofacial complex probably has the biggest effect on all these other parts. Obviously, they do not work in silos, but it is amazing how saliva and the lack of saliva can truly affect someone's life and ability to eat, speak, etc. So let's talk about spit. This will probably be more than you ever really cared to know, but it will also give you some context as to perhaps the symptoms that you're experiencing due to the dryness. So it's produced by 3 big glands: the parotid, the submandibular, and the sublingual. Much of the saliva we produce, is 90% of it is from these 3 big glands. But then throughout the whole mouth, we have hundreds, if not thousands, of minor salivary glands. So if you feel on the inner aspect of your lips with your tongue and it feels kind of bumpy, those are the hundreds of minor salivary glands that are also producing saliva. We are estimated to put out about 1 liter of saliva a day, which is a little bit gross to think about, but it is what it is. And to keep that in mind as we talk today, salivary flow is characterized as stimulated or unstimulated. Why do we make a difference? Well, think about it. Stimulated saliva is coming from when you eat or you're doing something to actually make your spit glands make saliva. Whereas unstimulated is, you're sitting at rest, you're watching TV, how does your mouth feel? And so those are very important distinctions. And then there are 2 types of saliva we make. We make them and it mixes in the mouth to make this kind of perfect saliva to help us function. So there's a serous saliva, which is a very thin, watery solution that helps with digestion and defense of the mouth, but it also just helps make things kind of move smoothly. And then we have mucus saliva, which is a thicker, more viscous secretion. It contains a lot of mucin. It really helps with lubrication. But if you keep this in mind, again, as we talk through this, you will understand why it may look like or feel like you have a ton of saliva, and yet your mouth feels dry. And that's because of the effects that whatever is causing your dry mouth has on the specific type of saliva. Our parotid gland makes serous only. So those patients who've gone through head and neck radiation for head and neck cancer and the parotids in the field, that will make a lot of sense to you all about why your saliva seems so thick and mucousy. Submandibular and sublingual glands make both kinds. So What does saliva do? It is incredibly important. I always joke that this, hematologists, and I work with a ton of hematologists, blood is their liquid. Well, saliva is my liquid. It's the liquid we know about, and it's amazing all the things that it can do. It's very, very protective. It first and foremost lubricates the oral cavity or the mouth. But within it, it also has antimicrobial properties, meaning that it helps keep germs at bay in our mouth. And our mouths are really quite dirty. It's like the dirtiest place on the body. In fact, if you get a human bite versus a dog bite, you are on much more involved antibiotics than with a dog bite. Nonetheless, we have a lot of microbes that live in our mouth and live there just fine and do their thing. And the saliva helps to keep them in check and keep them growing at the right pace, essentially. It also helps the mucosa or the lining of our mouth keep its moisture, its integrity, meaning that when you don't have you don't have enough saliva, or the quality of your saliva is not where it should be, you are much more prone to traumatic lesions, irritating your mucosa, your tongue hurting, burning, etc. It also helps to lavage and cleanse. And so you'll notice when you don't have enough saliva, you get a lot of food caught in between your teeth. It helps to naturally cleanse those things out. And you'll notice that you get food stuck in places that you never did before. It buffers, meaning that it keeps the pH of the mouth at a level that inhibits cavities, essentially. And then on top of that, it has components in it that remineralize the teeth. So it's constantly bathing the teeth and strengthening them. So think about all of those things. If you don't have enough saliva, how that effect can make short-term and long-term problems. It also helps with our food preparation, our digestion. It actually starts the digestive process. How we taste better when we have adequate saliva. And then certainly speech, how we talk. So what causes it? Well, there's a myriad of things. One of the most common causes of dry mouth is actually medications. There are over 1,100 medications that list dryness as a side effect, and they have a cumulative effect. So if you're on 3 medications that cause it, you're going to be more dry than if you're on 1. There are all sorts of autoimmune diseases. Sjogren's is directly an effect on the salivary glands, but there's also rheumatoid arthritis, lupus, scleroderma that have effects. Head and neck radiation, chemotherapy, simply being dehydrated can cause your mouth to be very dry. Tobacco use and mouth breathing. When we look at the mouth, it's very simple to see. We look at the tongue and see if it is enlarged, if it's cracked, and this is a very dry tongue in this picture. We often see fissures in the tongue or lines in the tongue. Sometimes people have salivary glands that become infected, and this is an infected parotid. You can see how the skin is red and it's swollen, and the earlobe actually everts, we call it. And then this is one of the openings of the parotid. We have this on both. This is the inside of the cheek when you open your mouth. You will see when you look and try to express saliva from it, it will either come out or it won't, or sometimes it comes out and it's infected and it has pus in it. And so we assess all of those things. So going on to the complications of dry mouth, these are all directly related to the lists of properties of saliva and the purpose of saliva. So we see mucosal abnormalities. We have many, many patients who are prone to biting their cheeks because they don't have that lubrication where their teeth fit together. We see patients with chronic candida, which in other words is a yeast infection. So that goes back to that antimicrobial part where we all have yeast that lives in our mouth and it just hangs out there and does its thing. But when it has the opportunity to overgrow, it will. And so having severe dryness or chronic dryness can predispose you to also having chronic oral yeast infections and chronic irritation of the lips and tongue. We see patients with coated tongues, and that is simply because the saliva is so sticky that these papilla, these little projections on the tongue, are not able to slough off like they normally should. And so what they do is kind of grow and stick together. This is not yeast. This is someone with a coated tongue. There's bad breath because all those bacteria are kind of out of control. Difficulty swallowing, and Kristin's going to talk about that. And obviously, it's the lubricant that helps us get a bolus of food down. We can have increased periodontal disease or gum disease because of the bacteria overgrowth. And then, of course, caries, which is our way of saying cavities or decay. And this is actually a radiation patient. So they are the driest of the dry patients. And what happens is they get a cavity and it progresses at an exponential pace. And if you don't stay on top of it, we are very often taking out all of patients' remaining teeth. So how we try to manage this is alleviate symptoms, prevent future complications, treat any conditions that are going on, try to improve salivary function, and then manage underlying systemic conditions, all with the main goal of improving quality of life. So we direct this at the palliative treatment of the relief of symptoms. Sometimes we can modify drug therapy if it's truly from dry mouth. We can offer salivary stimulants, either over the counter or by prescription. There are a variety of oral moisturizers, lubricants, salivary substitutes, and Aquoral, we'll hear about that a little later, and then pharmacologic treatments. So some really basic, simple, everyday things we can do is limiting alcohol and limiting caffeine. Now, this is not to say you can't have your morning cup of joe, or you're not going to listen to this Italian tell you not to have a glass of red wine here and there. But what it is for those people who drink coffee all day, or when I moved to the South, meeting people who drink sweet tea all day, those types of things that will further dry you out. We recommend no mouth rinses that have alcohol. So look for those zero or, Listerine zero and those types of things. Frequently sip water, staying hydrated, sucking on ice chips, patients who have dryness at night, having a humidifier in your room, using any variety of sugar-free salivary stimulants. In other words, we're trying to trick those glands into thinking it's time to eat. So you're stimulating them with gum and candy and lozenges. And so these are just a variety. These are none. I have nothing to report here. These are things that my patients have come in and tried, and many of you have probably tried some of these. But they often really like these Mighty Flow lozenges and gums that were developed for dry mouth because they have some healing effect. Some people don't like having gum or a lozenge or candy in their mouth at all times. So they try Xylomelts or Zero Strips. The key is sugar-free. And also the key is being mindful of the amount of xylitol you're taking in, because it can also cause you some GI distress or diarrhea and gas if you have too much xylitol. And then there are saliva substitutes, oral lubricants, oral moisturizers, however you want to call it. And most of them, many of them are water-based, except Aquoral, which is lipid-based. But they come in a variety of formulations, gels, sprays, etc. The issue is you got to find which one you like and like how it feels in your mouth. And so again, this is a list of some of the common oral moisturizers. And then certainly there are systemic medications that can be used that were made to help you make more saliva at prior to eating. That's why they were developed, but they're not without side effects. So if you tend to have reflux or if you have cardiac issues, these may not be for you. They do require functioning glands, meaning that if you're not really making a ton of saliva, you need to go into trying these medications with that in mind and manage those expectations. Other important information is to see your dentist regularly, simply because of the deterioration of the mouth that progresses so quickly with dryness. Be mindful of your oral hygiene and avoiding sugary food and drinks. But your dentist and your dental hygienist really can be great partners in your quest to kind of keep your mouth healthy in the setting of dryness. And we're not going to do questions now. And hopefully I didn't run over. All right, how do I unshare here?
Excellent. You have unshared, Kate.
I have, okay.
Yep, you were
now
good.
I'll mute.
Sounds good. And Kristin, did you want to add some more to this?
Well, no, that was an excellent presentation, Kate. And I just encourage, anyone to come to us with questions, and you can type them in the chat. And I know some people that I see, or some people that are involved in the Dysphagia Digest group that I run, they talk about having too much saliva or an excess of saliva. So we just encourage you, to talk about that with us amongst the groups, and we will talk about that as well, because we know for many of you, that's also a big problem. Or sometimes in the morning, you can have excess saliva, and by noon, you're as dry as the desert, right? So come to us, and we can share some knowledge with you.
Excellent. Thank you, Kate and Kristin. The next step here, I'm going to split us into 2 different breakout rooms just so we can have some more intimate conversations about this topic. The first thing you'll do is introductions, and I think the groups are pretty large. So if we want to do introductions through typing, that might be more efficient. So once you get into your group, if you want to type your name, where you're located, and why you're here with this meeting, if you're somebody who cares for people with xerostomia, or if you have xerostomia from treatment for head and neck cancer, you can put that in the comments so that we can get to know you and why you're here. I've tried to break out the rooms by providers and then by people that are directly impacted by xerostomia along with their loved ones. And then after you do your quick introductions, if you want to talk about how xerostomia affects your daily life, Kate and Kristin will kind of lead the conversations in the respective groups for about 10-15 minutes, and then we'll switch topics and talk about how you're managing and treating your xerostomia. So if we can make those kind of 2 separate topics, that's how we'll run the meeting today. So I'm going to split you into breakout rooms. If for some reason you feel like you're in the wrong room, you are welcome to send me a message, or Kate and Kristin can try to flag me down. I'll pop in between the 2 and I'll try to rearrange you. But I did the best I could with the information that I had. So you should see a pop-up that says split into your group or okay. So let's do that now and see how it. All right. So we're reconvening back all together here. Apologies for the confusion with the breakout rooms. It wasn't quite as smooth as I was hoping for with that, but I hope you had some chance at least to share and listen to other people's stories, at least for a portion of the time. I want to be mindful of our time that we have left. And so Kate and Kristin, I'm going to turn this over to you to kind of bring up some of the points that people had. I know from our group, we had a question about pilocarpine and the side effects from that medication. So Kate, I don't know if you can answer any more about that. But if you have other topics that were brought up in your breakout rooms, if you want to discuss those now, feel free.
So yes, I saw that message in the chat and I tried to type an answer and then got switched to so pilocarpine is a sialagogue, which means it is something that that causes us to make more saliva, but it has the same effect on any secretion type of gland that we might have. So one of the common side effects with it is sweating. Sometimes and that's not with everybody. Sometimes there are issues and effects on the belly, meaning that they get a little more reflux. Pilocarpine is kind of the older version of this sialagogue, and what they did was take this and make something called cevimeline, which is more specific to salivary glands. The issue with cevimeline is, of course, not all insurance companies cover it, and so it's expensive. But the other part of that is it is not without its side effects. So I would say my most common side effects that patients complain about is sweating. And some of them deal with it. You know, most of my middle-aged women are like, hey, I sweat all the time anyway, so what's the difference? Some of my patients who have reflux will just up their reflux meds.
Mm-hmm. And I saw there was a question that came on, or someone said about using a TENS unit. Well, a TENS unit is more used for pain and for sensory and for stimulation. Speech pathologists typically don't use those. Physical therapists and OTs use those. We use neuromuscular electrical stim, and I've never heard of that helping to stimulate salivary glands. I think anecdotally, I think some people feel that doing manual therapy work in the mouth and helping to go in and stimulate. Yes, I'm good. Kate, you're shaking your head. Yes. So yes, you feel like, yes, that may help. And I use that with my patients. Something that was also brought up was someone asked about, they've heard that acupuncture may help, but some in our group were saying, no, they've tried it and it does not. Do you ever recommend people try acupuncture, Kate?
I don't have someone who I can refer to for that, but I have known people who've had some effect with it, or some results. I mean, it is also very person dependent. You have to kind of embrace the whole concept of acupuncture. Right,
exactly. Let's see if we had really anything else. Some of the others were just sharing the different types of sprays and lubricants that they use. So that was helpful. And you shared some of your thoughts too. Someone asked about slippery elm or gargling with glycerin. I know we talked about gargling maybe with coconut oils or olive oil, just to at least help soothe the mouth, maybe especially with mucositis. I would imagine that would help lubricate.
Yes, and the other part, I know we're talking about dryness, but with mucositis, the keeping it as moist as possible is very, very helpful. I've had mixed results with, oil-based, rinsing with olive oil or coconut oil. My partner tends to recommend it, but I find that, a lipid-based product like Aquarel seems to work better than having all of that oil in there. But again, very personal preference.
Right. Oh, another thing that came up, what about Botox, Dr. Kate, for excessive saliva with people with head and neck cancer? Do you ever recommend that or no? Because then it can make them too dry, which can then cause cavities and caries.
So in the head and neck realm, I have rarely recommend. I don't tend to have people who complain of excessive saliva. The head and neck patients, it feels like excessive saliva. It's because of that thick mucousy saliva. We talked about that. A lot of times I'll recommend like Mucinex and that kind of thing. But Botox, you have to be careful with, especially in the head and neck realm, because oftentimes they already have some fibrosis of those muscles, those chewing muscles, and you don't want to do any more harm and create any more trismus, although it's also used to treat trismus. So I have found no effect with that, with obviously with dryness, but with overproduction, don't have a lot of experience.
I don't think I would even go there because it's going to last 3 to 4 months. And it's essentially titrate your response. And if you overshoot that response, you're shot in the foot for months.
Right. Right.
So Daniel is a pharmacist and a wealth of knowledge. Truly.
No. I'll tell you, and so I personally, I had a patient with Parkinson's that had excessive drooling, but now honestly, a lot of us know that's because of their sensory response and their tongue. They're not swallowing enough. And their neurologist did give them Botox, but now he's telling me, oh my goodness, I'm so dry. Now he's gone, the other way. So
Right.
I don't know. Right. It's
I like glycopyrrolate. I mean, I don't use that, but that is an option.
Yeah.
Glycopyrrolate helps with excess saliva.
okay.
Or atropine drops.
Atropine.
Right.
Okay. Oh, someone in our group has done Botox every 3 months for a couple of years, and it's worked. So that's sometimes it just depends on the person. I see here SRF, you've raised your hand. Did you have a question?
I was in the other chat room and I mentioned there was a study by a Dr. Bandy at Oklahoma State University. And she's kind of coming at it from a different way. She's a physicist and her daughter has had problems from cancer. And she's actually inventing a mouth guard that has I don't know, for lack of a better word, a trough in it. And you put liquids in there and it releases it throughout the night or throughout the time. And she's starting a study in January that I'm going to get involved with. I have no idea, but it sounded promising that it was already I imagine, she didn't say, but it was some kind of over-the-counter product or something else that it drops in there. So
I spoke with her yesterday, Dr. Donna Bandy, and she's getting FDA approval for this summer, she's hoping.
Yes, I think she's trying to avoid FDA approval because she's not going to introduce a drug. It's just I don't know, is it the right word, would be a process or something, but I'm sure it's changing daily. But so I'm hopeful
Well,
that
she said it'll be available in the summer then, I guess.
okay, yeah. So I think that's why she can have it available in the summer, because she doesn't have to do a big FDA study. But so that might be something. And I put in the other chat room, I put the name of the website that you can go to. I think it's
I went to,
swallowingdisorderfoundation.com.
I just went to her
Oh.
website
Yeah.
and she had, you have to schedule a time and she had no times available this year.
Yeah, she was looking for 100 people, and I think she found that number easily. But I'm happy to share more information in a follow-up email to everybody about that. But I do want to give Bennett Blakeman the opportunity to speak briefly. He's the CEO of Acoral, which is the sponsor of this meeting. So I just wanted to give him the opportunity to share a little bit about their product, and I will also send some more information in a follow-up email after this meeting. But Bennett, if you want to speak, go for it.
Yeah, thank you, Elizabeth. Thank you, the National Foundation of Swallowing Disorders. Thank you, Dr. Kate. Thank you, Kristin. Daniel, thank you for attending. I see some familiar faces from the Meet the Maker presentation we did 6 to 8 weeks ago or so. Acoral is a prescription strength dry mouth solution that we relaunched when Big Pharma gave up on it. The biggest reason we did was the patients who were relying on it, when they learned it was discontinued, were either crying or screaming because they couldn't get access to it anymore. It was a real game changer for them. And I'm not standing here trying to pound my chest suggesting that this is necessarily a perfect product for every single person. We want to be considered an option. The biggest differentiator for our product is that it is lipid-based, so it's an oil-based product. As highlighted, sounds like in some of your smaller group discussions, it's oxygenated corn oil at the end of the day. Yes, it's non-GMO corn. I promise it's very safe. It's non-toxic. We source it from France. They've got far stricter standards as far as the food that they put in their body than we do here in the United States. But what that technology will allow for is it will actually bind to your oral mucosa. It will hydrate your tissue, but then it will build a waterproof layer of protection so that you can re-engage in eating, drinking, talking, and not have it wash away, requiring such continuous reapplication. It's very small. A standard box comes with 2 10 milliliter bottles. So as you can imagine, that's about the size of ladies' lipstick. It will very easily fit in your purse, your pocket, your bedside table. Kristen's got one there. So it's handheld, very convenient and discreet to be used. Patients are consistently telling us they're getting 4 to 6 hours of relief, and ideally forgetting about their dry mouth for a little while so that they can resume the comfortability and normality, if you will, of everyday living. So I don't want to take up a lot of time. The intention of today was not to be an infomercial for a choral. It was really to get all you wonderful people together, hear from some healthcare professionals that you might not otherwise get the opportunity to hear from and meet and engage with. But it's a privilege to be associated with the foundation, Elizabeth. I just kudos to all the work that you do and the support that you provide your patients. So thank you very much for allowing us to be a part of this meeting and help you all with this.
And Bennett, I met you when you spoke at Chris.
I remember, Len. Yeah, how are you, sir?
Good. I just started my choral this week, finally.
Fabulous. I'm looking forward to hearing your feedback on that point. Ellen would kill me if I didn't mention this. We have a discount for everyone that's associated with the National Foundation of Swallowing Disorders. And we have a landing page that I can, that Elizabeth can share, but acoralspray.com is our website. And then if you just do /NFOSD, so just the acronym, it will take you to a landing page that we specifically created for all of you.
Okay, great. Thank you.
You are very welcome.
Looking forward to getting it and trying it.
Yeah, please reach out, Len. I'd love to hear your feedback. And if we can help further, we're happy to do so.
Great.
I just want to mention also, we do have a patient success coordinator. His name and his contact information is right on the landing page. So if you have any problems or questions or need some help, Zach is great at it, and he will make sure you get what you need without any challenges.
Wonderful.
Oh, great. Thanks.
Thank you. And thank you, everybody, for joining this group. This is a new experience for us to have a topic-specific support group. We had a lot of attendees, so I apologize if you didn't get a chance to truly introduce yourself and share your story. I know there's a lot more to it than what we had time for today. I'll send out a survey too, looking for some input and some feedback from you if this is something that we want to host in the future again. It certainly, to me, seems like there's a need and a benefit to this. And so we certainly welcome your feedback on that.